Hello, my name is Tasnim Arif, and yes, I'd like to present the predictive role of serum biomarkers in deciding how to manage patients with pediatric febrile neutropenia. So I have nothing to disclose. So febrile neutropenia is the second most common reason for admission in pediatric oncology, and it's surpassed only by admission for treatment of cancer. A typical febrile neutropenia episode is different to a typical adult febrile neutropenia episode. Children tend to have more upper respiratory tract infections or fevers of unknown origin, and there tends to be a lower mortality rate. So you'll have mortality rates of up to 3%, whereas in adults, the mortality rate can be between 4 to 13% instead. And so for this reason, there's a lot of questions and studies looking at whether we need to treat all patients with febrile neutropenia the same, and whether there is a cohort of patients who can have a de-escalation of treatment. And certainly in the adults, we have the MASCC scoring system, which helps with risk stratification, and that's been universally accepted along with the adults. But in pediatrics, there's actually 25 different clinical decision rules, and they all perform differently in different countries. So a clinical decision rule that's been developed in South America won't necessarily be applicable in England, and it needs to be validated within the country you're planning to use it. So recently, MASCC has incorporated the use of PCT and CRP in their risk stratification, and we decided to look at whether there was a role of biomarkers in developing risk stratification tools in pediatrics. So the aim of this systematic review was actually to build on two preceding reviews and to evaluate the sensitivity and specificity of biomarkers in predicting adverse outcomes, and to see if these biomarkers, if we could predict an outcome, whether we could de-escalate treatment by predicting whether or not someone would develop an adverse outcome. The review was conducted in April 2016. Overall, the quality of the studies was good. There were nearly 8,000 episodes from 4,500 patients from 11 countries across the world, and they looked at 30 biomarkers. We selected the top 4, which were CRP, procalcitonin, IL-6, and IL-8. And then we looked, first we looked at seeing whether a biomarker could predict a certain outcome. So for the purposes of this talk, I've selected CRP, and what you can see is a crosshair plot. The crosses denote each individual study. The horizontal and the vertical lines of the cross denote the sensitivity and specificity of each study. So sensitivity is longitudinal and specificity is horizontal. The circle, the large ellipse circle, it shows the 95% confidence region, and within that large circle, you can probably make out a smaller circle. I don't know if I can point with this, but it's right in the center of that ellipse, and that shows the pooled sensitivity and specificity of that study. So for CRP, thank you. For CRP, we have a pooled sensitivity of 45% and specificity of 65% with very wide confidence intervals. The different colors show the different outcomes. So what this plot is basically showing is that the red, which is bacteremia, is quite well predicted for CRP. The others, so the blue is denoted by clinical bacterial infection, and green is serious bacterial infection. They spread outside of the 95 confidence interval region, and therefore they probably can't be predicted as well with this particular biomarker. Now, although I haven't shown the biomarker plots for PCT, IL-6, and IL-8, they pretty much look the same. Bacteremia and severe sepsis is contained within the 95% confidence regions, but the other subgroups aren't. And that may be because in clinical practice, if someone has a serious bacterial infection, for example, a pneumonia, they may well have a bacteremia at the same time. So there may actually be some overlap between our definitions, and certainly within each individual study, although they were defining what they would call a microbiological defined infection, there was variation between each study as to what one group said was an MDI and what another group said was an MDI. We then looked at whether using biomarkers at different thresholds would be useful. So if we were to take this to clinical practice, which biomarker threshold would we use? We did this for all 4 biomarkers, but I have shown you the PCT plots. So we have PCT value threshold of 0.2, 0.5, and 1. And what you can see here is a ROC curve and a crosshair plot. So the curve of the chart shows the average sensitivities and specificities. And what you'd like to see is all the crosses kind of converging towards that plot. But you can see in the 0.2 graph, that doesn't happen. There's variation from the average, and there's also, although the sensitivity is well above 60%, the specificity is really wide and quite a wide range. For the higher PCT cutoff, as you would expect, you have a more specific test if you set your threshold higher, but it is less sensitive. And for that, it does assimilate towards the ROC curve better. So maybe the 0.5, the middle one, is the best level for PCT. The crosses converge towards the ROC line better, and they have a decent sensitivity and specificity score for them as well. So the previous data is evidence from one biomarker so one time point, but we wanted to look at whether serial biomarkers have been used, because as we know, CRP, PCT, the values change with time. We found in our review that only 10 studies looked at this, 6 were studied in the previous 2 reviews, and the meta-analyses for these were not possible, mainly because there was a variation in the way that the outcomes were defined. There was a variation in the way things were reported. There was a variation in what they were looking for as well. So we couldn't conjure up a lovely little plot to show you. What we did see from descriptive analysis was that the CRP seems to be more discriminatory after 2 days, and PCT seems to be probably most useful in that it goes up pretty soon after your event, and then it falls. IL-6 and IL-8 probably have no benefit in doing as a serial test. So our conclusions were that no recommendations can be made for a single point use of biomarkers to guide de-escalation or cessation of treatment. Serial biomarkers look promising, and there probably needs to be more studies looking at serial biomarkers. Bacteremia and severe sepsis can be reliably predicted by CRP, PCT, IL-6, and IL-8, and the ideal threshold for a cutoff biomarker after those 4 is probably PCT and probably at a value of 0.5. Just like to thank Bob, the CRD, and University of Birmingham. Thank you.